Hello everybody, this is my presentation on VTE prophylaxis. Prevention of venous thromboembolism, or VTE, can be defined as primary or secondary. Primary thromboprophylaxis is preferred because its efficacy is well established and it is more cost-effective than treatment of complications once they occur. Primary prophylaxis is the preferred method depending on your hospital policies, cost effectiveness, and the current standards. They either use drugs or mechanical methods. Drugs being low-dose and fractionated heparin or fondaparinux, and mechanical methods such as TED hose or maybe SCDs. Secondary prophylaxis is mostly for early detection, and it's reserved for patients who are either contraindicated or shown to be ineffective, usually with those with high clinical suspicion for DVT or pregnant women. The thrombosis risk assessments are individual risk factors that includes a history and examination of the patient, whether they are in risk of developing DVTs, such as those with sepsis or maybe known thrombophilia, prolonged immobility over 3 days, or age over 60 years. They total this up and determine whether they are at risk for DVT. There are several different methods of screening. I have noted the Padua score, a prediction score, and the improved risk score. There's also the Geneva risk score. So depending on what kind of risk you have, they determine what type or if you even need a prophylaxis. There's the low-risk patients who are there maybe for 12 hours, who are maybe ambulatory. It is not warranted to have any DVT prophylaxis. Moderate risk and high-risk patients should have DVT prophylaxis with drugs and or mechanical, more so for the high-risk patients to prevent DVT. There are those special populations who are at risk for DVTs, and they are namely heparin-induced thrombocytopenia. Fondaparinux may be used as an alternative to heparin. There's those who are at risk of bleeding, such as patients with GI bleed or intracranial hemorrhage. Mechanical methods are preferred, such as the intermittent pneumatic compression or graduated compression stockings. And there are others who are maybe going through, or patients who have stroke, who are pregnant, those with cancer, and patients traveling for extended periods of time. Pharmacological thromboprophylaxis is superior to mechanical devices in preventing VTE, namely low molecular weight heparin, low dose and fractionated heparin, and fondaparinux. Aspirin is not recommended in conjunction or solely for DVT prophylaxis. And Coumadin, it has delayed response time. It usually kicks in about 3 to 7 days after. So being in the hospital, if you start with a Coumadin, it wouldn't take an effect. So the risk for VTE is high. So the low molecular weight heparin example would be enoxaparin, 40 milligrams sub-Q once daily, and dalteparin 5,000 units sub-Q daily. There is the low-dose fractionated heparin. Dosing is 5,000 units sub-Q twice or 3 times daily. And there is the fondaparinux, which is 2.5 milligrams sub-Q once daily. But it depends on all of these depends on the creatinine clearance. Fondaparinux should be avoided in those with creatinine clearance below 30 ml per minute. This is a slide of suggested dose adjustments of low molecular weight heparins in adults with renal insufficiency. It just shows that creatinine clearance is very important in these patients, and some are weight-based dosing, so those are taken into account in how to dose the patients for VTE prophylaxis. Here are examples of mechanical methods of thromboprophylaxis. One is the intermittent pneumatic compression, and the other is graduated compression stockings and venous foot pumps. These can be used with low-risk patients and in conjunction with drug prophylaxis with moderate to high-risk patients. So that concludes my presentation for VTE prophylaxis. I derived most of my information from UpToDate, and there is an awesome guideline for VTE prophylaxis from American Society of Hematology, and I have noted the link here. Thank you, and you have a good day.